Good morning, everybody. Just as our meeting is filling up with people coming in, I'll introduce myself. I am Hazel Cheeseman. I'm Deputy Chief Executive at ASH, and this is the third of four sessions, sorry, I should say, that we are doing looking at a piece of insights work that we have undertaken with Bluegrass, who we'll be hearing from shortly, looking at the attitudes and behaviours of different groups of smokers and healthcare professionals. So today our focus is on pregnant smokers. If you've missed the previous two sessions, they either are or will be shortly up online. And the first one looked at kind of the broader issues around COVID and cost of living to smokers in disadvantaged circumstances, and then the second one focused in a bit more detail on the lives of disadvantaged smokers, particularly those in social housing and people with mental health conditions. So if you haven't seen those and would find them useful, we will circulate the link afterwards, and they will be or are already on the website. But today our focus is on pregnant smokers. And do you want to move to the next slide, Amy? So we have a presentation from Sonya, who is the director at Bluegrass, who's undertaken this research on behalf of ASH. And then we're going to hear some responses from Hilary Wareing, who I'm sure that many of you will know on this meeting and needs almost no introduction, but is a director at IPIP and has a long history of working with pregnant smokers and with systems and services to improve the support to pregnant smokers. And then we'll also hear from Jane Coyne from Greater Manchester, midwife, again by training. Oh, I think Hilary is too, who will talk about the kind of Greater Manchester approach and reflections on what we've heard from Sonya. And then we will have hopefully a lively discussion, which we'll look forward to looking at your comments in the chat and discussing the implications of the findings. So Amy, do you want to move to the next slide? Just a bit of housekeeping. So we're recording this. The recording will be circulated. It will be up online. We'll circulate the slides. Everyone keep themselves muted and turned off unless they're speaking. And then do, comments, questions in the chat. The more the merrier, please. That would be great. And then if you've got any issues which are not being resolved, you can always email the admin email address there. That would be great. Next slide, Amy. Yes, and though just to trail our final session in this 4-part series, which is 2 weeks Tuesday, on healthcare professionals. I imagine that we're going to touch on the role of midwives today. Certainly we can bring those in again when we discuss them on Tuesday on the 18th. But there will be a closer focus on primary care in that discussion. So looking at the kind of role of GPs and pharmacists. And throughout the sessions, various issues have come up that have related to primary care provision and the role of healthcare professionals. So hopefully that again, will be a good summing up session in a couple of weeks' time. And those of you that have questions that relate to that, come on to that session and table them there. Right, I think that's probably my last slide, isn't it, Amy? Oh yeah, the purpose of today. Right, thank you. So we're going to do a deeper dive into pregnant smokers and new mums and look at how the research, the insights that the research gives us for thinking about service delivery. So I don't think I'll talk anymore. I'll hand straight over to Sonya, and I will let you kick off, Sonya. Thanks.
Okay. Good morning, everyone. Can everybody see that?
I can see it, Sonya.
Fabulous, great. So thank you very much, Hazel, for the introduction, and lovely to see so many people here today. As Hazel said, I am a director at Bluegrass Research, and just going to take you through not a particularly long presentation today, but hopefully crammed full of really interesting information. So this presentation draws from, as Hazel said, a wider research project that we undertook for ASH earlier on this year, with an idea of looking into really a deep dive into the nation's smokers and their lives using qualitative research. So we did some group discussions, some depth interviews, and this presentation pulls on the work that we did with pregnant smokers which was only 6 depth interviews, and they were all from the northeast of England, but also incorporates the findings that we took when we did a literature review, which included the reports that we've got listed here, which range from 2016 through to 2020. But I think a lot of that is still very valid. And so what I've done is incorporated both the desk review and the depth interviews, the primary research that we did, to look at attitudes, behaviours and perceptions of support for quitting in pregnant smokers. So I think, you know, the starting place for all of this is if you speak to someone who has smoked through their pregnancy or is currently smoking through the pregnancy, they know it's not a good thing. It's not that they are unaware of the fact that there are harms associated. And I think what we see with pregnant smokers is almost like a normal smoker's attitudes, but on steroids almost, because we see with everyday smokers, they talk about social stigma, the feelings of embarrassment and shame, you know, that's exacerbated by the requirement to stand outside of the pub. You know, they're like social outcasts a little. And I think that this is just enhanced during pregnancy. And there is certainly, you know, I've spoken to quite a few pregnant smokers who hide when they smoke. They wouldn't do it if anybody was watching. When we speak to them, they have very mixed opinions on how common it is to smoke through pregnancy. There is a recognition by some mums and mums-to-be that it's increasingly less common to find people smoking throughout the pregnancy, but others live in a context where actually it's not unusual, and their friends have smoked through pregnancy, perhaps their parents, their mums did. So it's, whilst they recognise that it's not ideal, as they would say, they don't necessarily feel it's terribly unusual, and they tend to equate smoking through pregnancy with drinking alcohol in terms of the risk that it involves, and definitely position it as not as bad as drug taking. Something that comes out quite strongly is that there is a belief amongst a lot of these ladies that low levels of smoking are fairly harmless. So they feel if they can cut back, then they are massively reducing the risk and potentially, you know, almost negating that risk there. And there's a quote here from a mum of 2 that we spoke to about, well, she will be a mum of 3 by now. I could understand if I was sitting taking drugs. Do you know what I mean? Like if I was sitting puffing on 20 to 40 tabs a day, you can tell she's from the northeast, tabs a day. I get that 5 tabs is still 5 tabs, but it's nowhere near as much as what I've seen other women smoke in their pregnancies. I just feel like I'm being constantly judged, like I'm cutting down the cigarettes. I mean, 2 a day, to be honest with you, that's absolutely nothing, to be fair. So a real perception that, you know, and we'll move on to this, that it's almost, you know, so difficult to quit, but actually cutting down is almost as good. When we look at pregnant women, because a lot of them can be quite young, certainly in Bedfordshire, some of the people that we spoke to were really very young, and it can be the first time they try to quit smoking because they fear of harm for the baby, and it can be their first sustained effort to quit. When we look at talking to women about, they know it's bad to smoke, but what exactly, you know, are you risking by smoking through pregnancy? What is their understanding of the health harms? There's a very mixed bag of understanding and awareness of the health harms. People can be aware of certain things but don't really understand what the implications are. Knowledge accumulates over pregnancy, so if you have several babies, there is a building up of the awareness and the understanding as you move through pregnancies. But also, as I'll come to later, if you have smoked through a pregnancy and had a healthy baby, then that kind of feels like it gives you the go ahead to carry on doing it. So whilst their knowledge might be growing, their rejection of the risk is also growing. So knowledge tends to accumulate over pregnancies, but tends to be around impacts during pregnancy and at the time of delivery, with much less thought about longer term developmental developmental issues with the baby. And when you talk to people about issues once the baby's born and is developing, that's much more associated with alcohol and FASD. There is a perception amongst some women that smoking towards the end of the pregnancy might be less damaging because they lack the understanding of the development stages of the baby. The greatest awareness is around oxygen deprivation, so that they very much make the link between smoking and lungs and oxygen and the baby, and underweight and small babies. But they don't, as I said, they don't necessarily understand what that means. I spoke to one, I will call her a young girl because I'm an old lady myself, but she was a young girl, young pregnant girl. And she said that she understood that that just meant it was easier to deliver the baby, you know, that there wasn't actually any problem with the baby, it was just small and therefore easier to deliver. Of course, not everybody thinks that way. Some women talked about additional scans can reassure rather than deter them from smoking, so it reassures them that everything's going okay, so they can continue to smoke. They associate smoking with damaging the baby's lungs. One lady spoke to us about a premature baby being deprived of oxygen, and so actually it was developing better outside the womb of a smoker, so it's probably a good thing if you delivered a bit early, because that would be better for the baby. Other things that people associate with smoking in pregnancy, they talk about a baby being born with a nicotine addiction, asthma or breathing problems in the newborn baby. Poor development, but typically they're talking about poor development during the pregnancy, and they're not terribly specific about in what ways that development is being hindered. Miscarriage, premature delivery, stillbirth, and sudden infant death syndrome are all things that people talk about, but don't always focus on an awful lot. In terms of their attitudes to those risks, it's hard to listen to those conversations whilst you want to carry on smoking. So some close off to those messages. They don't want to hear because they don't want to feel more guilt, more shame. And the guilt and shame and the feeling that they can't quit, or the actual inability to quit, can create additional anxieties. And some growth scan, extra monitoring, whilst it also gives the ladies, as we said, some sort of approval that everything's going okay, therefore you can carry on with smoking. It can also make them more anxious, increase emotional turmoil, as well as reassuring, or instead of reassuring. As we said, some smokers kind of are at peace with it, if that's a good way of putting it, and that's enhanced in ladies who've had healthy babies before and smoked through those pregnancies. And mental health, as with all smoking, is a big factor in all of this. People, lots of women have talked to me about how quitting would add stress to them and therefore add stress to the baby and wouldn't be good for the baby. So, they can weigh up, is additional stress and anxiety going to be worse for the baby than actually smoking a few cigarettes? As we've talked about, I've touched on, the impact of messaging depends on whether it's your first or subsequent pregnancy. First pregnancies respond much more positively to harsh messaging regarding negative consequences at birth or even death. And there is a need to communicate harm to the baby to get people to start thinking very seriously about this. If you've already smoked through a pregnancy, messaging is less impactful. Women are more cynical. They feel that, well, you tell me this, but that didn't happen, so why should I believe it? I've had a healthy baby. Both groups respond positively to messaging regarding the suffering of the baby during pregnancy. And I think that word suffering is possibly the big word there, isn't it? It gives an urgency, it gives a direct responsibility to the mother, and it's also less easy to dispute. They can't see whether that's true or not, so it's quite hard to dispute those messages around the baby suffering in utero. Softer communications approaches don't tend to work, although pregnant ladies will say, oh yes, that makes sense to me, and you know, they'll respond positively to it because they don't want that pressure. Actually, they're not as motivating as the more harsh messaging is. A very interesting quote here. I was just happy continuing, really. It was more of a case I was thinking about quitting and cutting down before pregnancy, and then I got pregnant and thought it was a decent excuse to cut down. But I don't know, because I smoked during my first pregnancy and she's perfectly fine, happy and healthy. So I'm all right myself as sort of, you know, well, I carry on how I am. I have the opinion that it's my life, so I can do what I want to do. And so she was continuing to smoke. She'd reduced how much she smoked, but she continued smoking throughout the pregnancy and was reassured by a successful previous pregnancy. So as I said, mental health and stress is a significant barrier to quitting, and this idea that the stress of quitting might be worse for the baby than continuing to smoke at low levels. And moderation dominates quitting behaviours. So they talk about cutting down, they talk about reducing. We've heard that quote from that lady who's saying that just 2 a day, you know, what is that anyway? Quitting entirely is seen as too stressful. And encouragement to cut down is common. These ladies are being encouraged to cut down, to reduce their smoking, and they see that as the go ahead not to quit. They have a fear of being judged, and that can reduce their willingness to access advice or listen to advice. I'm not going to go and ask someone for help to quit smoking because I'm very embarrassed that I smoke in the first place while I'm pregnant. They fear blame, and that's understandable. We hear about a real mix of experiences with doctors and midwives, stories of feeling pressured, feeling that healthcare professionals are being patronising. A lot of discussion, particularly not so much amongst the ladies in the northeast, but certainly when we talk to the ladies in Bedfordshire, saying, well, yeah, they discussed it, but it was a bit vague, and they kind of said, here's a telephone number, but I didn't follow it up, nobody followed it up with me. So, and it makes it much easier for these people not to take up that offer of help. So there needs to be ongoing engagement, ongoing explanation. This is how you can seek help. This is how you can get help. These are how we can help you quit. These are the methods that we can use to help you quit. All of those messages need to be ongoing. Quite a lot of discussion, and certainly the work that we did in Bedfordshire, we did some depth interviews with couples, and we did some separate ones with dads, and looking at how a smoking partner can impact the pregnant mother's ability to quit, or perceptions about quitting even. And there's definitely a perception, and we see this with smokers anyway, that if you're quitting with someone, it could be an easier way to go, and they feel that if their partner quit with them, that would make things easier for them, but they feel unable to force that partner's behaviour if they're not volunteering to quit with them. They're often not ready to quit themselves, so they find it very hard to ask the husband or the partner to quit. And there is a perception that if both of you are grumpy as hell because you're quitting, then that is a very stressful and tense relationship. There's a lady here who's quite interesting. I tried to cut down through this pregnancy, but it was a lot harder for us to do it because I was kind of stressed with the baby's dad at the time. I was getting stressed with my firstborn. I was getting stressed with family members and stuff like that. It was a lot harder for us just to quit. When she says us, she's from the northeast, so she means me, not her and her partner. It wasn't until the end of the pregnancy when I was actually in labour and then got out of hospital that I quit, because I just don't want a tab anymore. I can't do this. I've got a newborn at home and I don't want that newborn to smell of fags. So there's an interesting example of someone who managed to quit after the event. So after she delivered the baby, she found it easier to quit because the pregnancy itself and the context of the pregnancy rather than necessarily the pregnancy itself was quite stressful. That said, in my time speaking to smokers of all sorts, I've come across a lot of women who have given up quite successfully throughout their pregnancy and then taken up smoking again as soon as they deliver. So that's another question. How do we keep that quit secure after delivery? So what comes out of all of this work, both the desk research and the one-on-ones we did, was that, you know, it's not rocket science, but the relationship with the midwives is key. They're seen as the main source of information for pregnant women, and they're relied upon to create a positive and honest and non-judgmental environment. So that's what women want from their midwives. And actually they recognise that the midwife has a duty to try and get them to quit smoking. It's not that they don't expect the midwife to talk about it. They do. They understand that is something that the midwife has to do. And a development of a close relationship can overcome that shame and embarrassment that they have regarding smoking. And it's the perennial question of how do you strike that balance between what we've seen as the requirement for hard-hitting information and that, you know, that suffering of the baby in the womb, and remaining supportive at the same time. And there's no doubt about it, that's a very tricky tightrope to walk. A conversation needs to be ongoing. And here's a quote from someone who says, you know, they should encourage you to stop smoking more and be more onto it. They never really encouraged us or pushed us to stop when they could have done. So this lady had a discussion, hadn't been ready to quit at the time, and obviously the midwife hadn't felt that she could keep on revisiting that topic, whereas the mum felt that actually perhaps she should have done. We certainly had some good examples where midwives were able to honestly address the subject of smoking during pregnancy, and yet the mother felt that they remained supportive and understanding and didn't feel judged. Lots of smokers, pregnant smokers, talking about different ways of quitting. That's what we hear all the time as smokers. Nothing is the right thing for everybody. Talking about vapes working, some experience of positive experiences with nicotine replacement therapies, but for every positive one, also a negative one where it didn't work or it caused problems. The CO monitoring was seen by some as a positive encouragement to quit and stay quit. We spoke to some ladies who'd had the ability to test for carbon monoxide at home during the pandemic, and it had a really positive effect. They were liaising with their midwives about it over some sort of digital means, the telephone or Teams, and they felt supported in that way, but also they felt quite in control and engaged with that testing, so that helped them with their quit attempts. So just to summarise those key points, you know, the context is that these ladies know it's not good and they are guilty about smoking. They feel ashamed that they smoke during pregnancy. They feel able to justify it, some of them, whether that's because they feel it would be too stressful and therefore harmful for the baby to quit. As we've said a few times, others are reassured by previous problem-free pregnancies where they smoked. Very mixed, patchy awareness of specific harms to the unknown baby, and much less association with any harms that come to pass after the baby is born. And even if people, as I said, are aware that this might happen or that might happen, they don't necessarily understand the dangers of those things. Also, something I've not said in here is that we have spoken to ladies in the past where they've talked about abrupted placentas, things like that, but have never been told that that might have been associated with smoking during the pregnancy. And so they can therefore continue to go on and feel that they've had a successful and problem-free pregnancy, even though they've smoked, because they don't know that those things are associated with smoking. The greatest awareness of health harms is around oxygen deprivation and underweight babies. There's some experience the experience of smoking through previous pregnancies and delivering healthy babies is very, very significant to the attitudes that you go into a subsequent pregnancy with. A recognition and acceptance that the midwife has a role to support and encourage quitting, and lots of good evidence that positive relationships can encourage women to persevere in their quit attempts. So I shall stop sharing.
Fantastic, Sonya. And I don't know if you can tell how much your presentation has provoked chat, but there's lots of questions, lots of chat, which is fantastic. Please keep posting your comments to each other. I'm going to invite Hilary to come and join us now. If you want to turn your camera on, Hilary, and thanks, Sonya, and we'll invite you back for the Q&A. There's quite a lot of conversation about e-cigarettes. We might talk a little bit about e-cigarettes in the Q&A, but I think maybe that might be an issue for us to come back to again. We haven't done a webinar on e-cigarettes and pregnancy for a little while, and we have got some new research which I'll post in the chat. So we might revisit that in another webinar in the future. Right, Hilary, over to you to get your reflections. Thank you.
I'm hoping that PowerPoint's going to go up any second.
I can see it. I can see it.
Yay! Okay, great. There was a huge amount in there from Sonya, and I've kind of seen this before, the presentation, so what I'm going to try, but I've heard even more listening to that today. So I'm put some slides together, which I'm going to go through fairly quickly because I know you'll get them afterwards, but picking up and on the key things that Sonya's presentation showed, because I think it's really important. Some of it is coming from lots of different insights, and it's really important we focus on the key things we can do. So let me go to the first slide. So what do women say? Lots of things that's already been said. It's mixed messages still there, actually. And it's not just mixed messages from professionals, it's mixed messages from the wider community and families and households as well. So we as health professionals need to be very strong in our messages about what the facts are. Not everybody having the conversation that's already come up. It's really important that this just does not come from the midwife. Attitudes to risk, I think, is an interesting one, and that also comes back to what Sonya said, and we've heard it as well, about alcohol and drugs. It's different. That changes my behaviour. I wouldn't do that. Smoking doesn't change my behaviour. It doesn't stop me being a good mum. He's fine. My last baby was fine. So heart sinks. I think there's some heart sinks that as professionals working with pregnant women we all hear, and we need to think that how we can pick those up, and rather than thinking what do I do about that, actually changing them. You know, my last little boy was fine, so I'm really pleased about that. Let's not argue that. I'm really pleased about that, and I want to help you make sure that the same happens with this baby. Social networks, yeah, we have to remember in some places around the country that smoking is still a norm in some social groups. What bad is? Bad, small, those words do not particularly resonate with a lot of women. We need to be more specific about what that might be. You know, if small means being on a ventilator in a neonatal unit, not being able to go home with them after the birth, we need to explain what it means, and that comes on also to using things, whoops, sorry, I've gone to using things like visual images to help people understand what bad looks like. Though I'd say be careful with visual images. What we think as health professionals might be shocking may not work for our pregnant population. So it's about using images that don't necessarily resonate with us, but resonate with the women that we're actually working with. Not patronising, not judgmental, good conversations. They want a truthful conversation. And in fact, more than anything, it has to come from the midwife to begin with. Midwife doesn't say anything, then actually it lessens the impact of other people. But it needs to be honest. And in all of our kind of insight, we recognise what Sonya recognised is that honest, good conversations are valued by women. Whether they decide to make a change or not, they see that as the role of the midwife, having that honest conversation and giving them the information to make the choice about what they do and not keeping information to ourselves. Do it every time, because next time might be the right time. And I think that's really important. And I'm seeing that happening more and more, is we need to keep raising the issue. It might be hard, but we don't know when the right time's going to be for that woman if it wasn't when we first mentioned it. And just appreciating the lives that women live and the complexity of some of those lives. So that ongoing support, really important. So that's again affirming what Sonya said. You know, we need to, it's not a moment, it's not a month, it's not 2 months, it's not 3 months, it's ongoing intensive support that reflects their lives and their needs throughout pregnancy. There's been quite a bit mentioned about postpartum and between, you know, before pregnancy, between pregnancies. There's a really big role for health visiting here, and I think that's starting to emerge, and lots of services, health visiting services are starting to do more around smoking. And what they want from health visitors is very much the same as they ask for from others, and they see it as a health visiting role. They want those not one-off conversations, ongoing conversations. They want it to be related to their lives. They want to involve the people around them. This was in pregnancy, but even stronger postnatally, because it's that smoking in the household and the triggers for them, but also the harm they realise that can cause for their babies. One thing that I think is worth mentioning as well, that maybe hasn't come up as much, is how we do that, maybe not always face to face, and the pandemic gave us an opportunity to look at this within Greater Manchester, who, and I'm sure Jane will say more about this, who used individual CO monitors during pregnancy and offered remote support. It was really highly regarded by women. And what was interesting that we picked out from that work, which is really recent, is the increased knowledge we heard from women around smoking in pregnancy. So that the Insights team said they were really heartened by the amount that the women knew about the harms to their child, more so than they've heard in other Insights work that they've done. Another interesting bit that I think comes out from COVID into other areas as well is the fact that the women realise that you can cheat with IQOS or with any other CO machine. They realise that you could get somebody else to do it if it's remote, or that you just don't smoke for a while beforehand. And they perceive that professionals might think they're cheating, but what they were telling us is we'd only be cheating ourselves. And I think there is a presumption sometimes that women don't tell the truth about their smoking. And I know there's some research around that first ask at early pregnancy, but I think when they're with us, what we're hearing is we need to be truthful, because it's not about cheating you, it's about doing the right thing for us and our babies. The advisors were what made the difference. And what was it? They were able, because they were doing remote, to be very responsive. They could pick up and proactively and reactively have contact with that woman when she needed it, rather than just in appointments. And while I think there's a real value to face, I think that what we found out during this Insights work is that we perhaps need to be a little bit more flexible than maybe some of us were before COVID, to help women get the support at the right time and to help them not relapse. Another group we just to focus into, because I know we've been talking about a lot about people living in poverty and in social housing, etc. But also just looking at Eastern European women. We looked particularly at Romanian women in a small study because they were not engaging with the local stop smoking offer. And it was about learning about their lives in the UK. Many who we talked to had also had a child out in Romania, and their social isolation, their language barriers, and also cultural norms, and their way their families actually work, and also the type of healthcare that they've been used to back in Romania. So, for instance, they don't have an equivalent of midwives. I know I've done some work out in Eastern Europe, and it's much more medically based. So it might be more about making sure that the medics are on message on this, as well as the midwife, perhaps spending more time explaining about how the system works, looking for real opportunities to build trust in those local communities. And we heard very loudly that it was about involving the family, that this should be a whole family approach rather than just them as the pregnant woman. And incentives, just to pick up on, given we're looking at this a lot, that was something that the group we talked to felt would really resonate with them, that it was part of a contract that I'm going to do this and I am going to get some recognition for it, and something that may well actually help my family as well. So that well done for making that change, and doing something that's really hard. So I'm conscious of my time. So my key messages would be women-centred, about their lives, enabling and ongoing, learning to cope with the heart sinks, not being kind of caught off guard by them, and not being able to respond, but thinking what those might be and what you might say before it actually comes up, relating to their lives, everybody doing it, but particularly the midwifery team, and offering ongoing and intensive support, not just during pregnancy, but postpartum as well. So we don't just help people get quit, but we can actually help them stay quit. Thanks.
Brilliant. Thanks, Hilary. I think that really adds to the conversation that we're having as well. I'm just going to invite Jane, if you stop sharing, Hilary, invite Jane to join us. And if you can be as quick as possible, Jane. Sorry, you've got the kind of last slot.
That's all right.
Hilary, ask to stop sharing your slides.
Yeah,
sorry.
Can I have the opportunity to share? My share isn't working.
Yeah,
it might be for the sake of speed. If we have your slides, maybe we could share them.
Okay,
yeah,
that's fine.
Up now.
Thank you. Thank you so much. Brilliant. Yeah, so as you know, obviously I've been in Greater Manchester now since 2018 and been a midwife now for about 25 years. I am that old. And we've been delivering the smoke-free pregnancy programme really successfully. Obviously with multiple interventions working across the pregnancy continuum. You could change my next slide, Amy, please. Obviously you all know that smoking in pregnancy is a major preventable risk factor, and obviously hearing it from women, I think what the insights that tell me is that the risk that we think we know about, that women actually do know those risks as well, but actually don't use them as an impacting aid to kind of make them quit. And obviously we started our programme in 2018 in a response to some of this, in the rates not falling as quick as they can. And I think through our integrated approach, we've had more than 3,500 pregnant women and their partners and family members quit smoking since we started. Thanks, Amy. Next slide. And just to show obviously what can be done, I think the insights from actually doing a system-wide programme shows that kind of that pink line is where the GM programme started. Obviously SATOD was milling about before, and obviously ever since then we've seen a really rapid decline in smoking at time of delivery rates, even during the pandemic, which tells us we've got a lot of evidence base to say what we're doing is actually beginning to work. Thank you. I think the main insights from what I'm hearing today is obviously the role of the midwife, and being a midwife myself, I think, you know, women often come to us, don't they, in understanding that everything we say more often than not, they ultimately believe and want to kind of please us and make sure that they're doing everything they can to make themselves and their babies, you know, really healthy during pregnancy. And obviously carbon monoxide should be the first for carbon monoxide testing should really be the first foray into that midwife having that very brief advice conversation. Carbon monoxide testing for us was absolutely essential, and we made it kind of mandatory trainings that everybody gets annual training on this, plus an e-learning module to enable midwives to have the confidence to actually deliver a really good conversation. I think the problem is sometimes that midwives are really unsure how to have those conversations in a real sensitive manner, but also making sure that they get the messages of the harm across to the women. I think actually utilising the carbon monoxide monitor allows women to medically see something is maybe not quite right, you know, that the machine is flashing red or amber, depending on their carbon monoxide levels. And that really gives a really good visual tool and allows that midwife to really then begin to have a good conversation and make that kind of direct opt-out referral. Opt-out referral is essential. Women say if it's important to you, you know, it's got to be important to me. And if you're going to do something about it and it's important, you're going to do it there and then, like we would with many other things such as raised blood pressure or bleeding or anything we would act on that there and then. And the women say that the sooner we can make that referral and get them an appointment, the more than likely to attend it. Well, no, they're not going to be waiting for somebody to ring them a few days later or a week later, because that actually the insights from women is that isn't important to us enough to do something about it. In GM, we actually took the approach that the midwives would ring direct to our services. We have a specialist maternity-led stop smoking service across the region, and the midwives can ring directly into theirs and get an appointment, which is absolutely key to ensuring that women are engaged and wanting to come back and see us. And we probably found the increase in uptake from about 20% of women making referrals coming across about 60 to 70%. So obviously making sure that rapid referral happens really quickly really increases the women's time to engage with us. And then what they did tell us is those specialist maternity stop smoking services have been their absolute lifeline. They see them in the uniform, they see them as part of the maternity journey, they see them as part of their care pathway, and they don't see it as something different, they don't see it as an external service that's stigmatised, they absolutely just see it as part of their maternity care, and that has driven kind of engagement with services. We do offer risk perception intervention, and that's an additional motivational interview which occurs after the booking scan for those women who still smoke. As we know, for some people it will take up to 30 attempts to quit, and like you said before, I think it was Hilary, that obviously this is the first time that some women will have considered stopping smoking because they're pregnant, so it is going to take sometimes, you know, multiple attempts for them to get where they need to be. And we've found incentives have been a real good hook to that as well, so really good at getting women in and kind of getting the women to quit and continuing to engage them through care. We offer electronic love to shop vouchers, and women have said this has been phenomenal. And I think the other thing they have said is during the pandemic that the incentives have not been stored up and utilised for, you know, the niceties. They're using them for activities of daily living for themselves and their babies. So have been a real important lifeline. Data analysis is key, but also I think what we are learning even more is that, you know, that whole system approach, working through the pregnancy continuum, monitoring when people are coming back into the programme, be it 28 weeks because babies are smaller and women are beginning to see the effects of smoking during pregnancy is key. But also we're going to be working with the University of East Anglia to kind of move into that postnatal period and with your Love Your Lungs project to work with neonatal units, and also working with our health visitors to ensure that that programme is absolutely extended into that postpartum period. We are doing a significant other scheme, so we support an other family member or partner to quit smoking alongside mum, and that insights has given women confidence to do that. They feel like somebody's in that with them, and obviously preventing that household smoking and relapse prevention within the household as well. Thanks, Amy. And obviously we know, what we've mentioned before, is that we know that smoking is particularly demonised and a stigmatised activity, and is not always related to the level of risk to the fetus, and it can be seen as a bit of a more of a moral judgment. You know, how often do we hear it's a lifestyle choice, women can just quit, you know, and when we know now that it's addiction and we need actual support to do that. And really important that we can see through our programme is that we're meeting the needs of majority of those socioeconomic groups coming through, and that we're meeting kind of all the diverse groups with lower socioeconomic groups more likely to quit during pregnancy, and obviously reinforcing those health inequalities. And obviously you can see as well we're touching many ethnic groups who are coming through to us as well, so that we're really interested to see the programme is working with majority of smokers coming through our door. Thanks, Amy. We did a phased implementation across our system, and obviously then that led to us continually comparing our data and understanding what worked well. And obviously we did have maternity stop smoking teams as well as local stop smoking services. And the insights we gained from that, women actually, were 4 times more likely to engage with the maternity services, and hence why we moved to that approach. And more often than not, and I think Hilary alluded to that as well, everything that women said is that the difference that made the difference was that continuity of the specially trained maternity support worker, having that same person there from start to end, really drove their quit, knowing that they could go back to them if they relapse, and they were going to be there as that supportive face was absolutely brilliant. Thank you. What we've achieved, I think, standardised pathway, women being, no matter where they go, they're getting the same advice, they're getting that consistency of approach, the same training for all staff members who are kind of dealing with pregnant women, levelling up of inequalities, increasing engagement with bespoke maternity stop smoking services, reducing the number of babies requiring neonatal care, which will impact on women's health, not only in this pregnancy, but in their future pregnancy, and how they choose to maybe take their quit journey forward after they've had their baby as well. But I think I've got one more after that, Amy, ever? Yeah, and I think, as we said before, just around adapted during COVID, obviously ICOs, women help them prove their quit, help me to account themselves, spurs you on and gave them the push to carry on, a script for midwives so that we can make sure that they can perform impactful brief interventions, and just to really shout about the maternity support workers, they're the lifeline to everything, and that's a really important quote that came from our midwives and women. Thank you.
Fantastic. Thanks,
oh,
Jane.
go on. You can share them after Hazel.
Oh, yeah, brilliant. Okay, we will do. Right, I'm going to invite Hilary and Sonya to join us. Such a rich conversation in the chat. We're definitely not going to cover all the ground. Where to start? I think I'm very interested, I think, in this like the balance that we need to strike in engaging women, not frightening women, but being honest. And it came out from all of your presentations that women do not necessarily, they know that there is harm, they don't necessarily understand what all of that harm is, and it's coming out in the chat as well, that the challenge of speaking with impact without alienating our smokers. If you maybe Jane and Hilary could just add a few more reflections on how we can do that, and note in the chat that maybe there's a bit of a poverty of understanding among some of our healthcare professionals as well, because we're not all working on this all the time, and a request that maybe we should do a webinar on the health harms, which we're certainly happy to do, and perhaps we could combine that with a further conversation about what the harms are and how you talk about them. So maybe some initial reflections, and like you can come back in a few months' time and we'll go into it in more detail. Jane, do you want to kick us off?
Yeah, I think definitely. I think as professionals, we don't necessarily get the training to the level that we need to be able to deliver those brief conversations. So for us, giving staff confidence around those conversations and the harms that from smoking has absolutely been imperative, enabling them to then go and engage with women and have a decent conversation. So I think it's giving staff the empowerment to have those conversations and say things in the right way, and not necessarily colluding with the harms of tobacco. Is absolutely key.
Colluding with the harms, I think, is really good. And I think, we're talking about pregnancy today, but you see that in the mental health space as well. Yeah. That kind of collusion with underplaying the harms that we're talking about here. Hilary, have you got anything to add briefly before we?
Yeah, I think we have to remember, I mean, one of those insight studies we did was on nearly 200 women. Mm. And one of the things that came out was every woman said the thing they wanted was a healthy baby and to be a good mum. And for some of them, that was going to be an easier journey than for others. Yeah. And I think what we have to concentrate on is we're helping them reach that aspiration that they all had. And it's about, for me, telling women that things that might help them do that. And you want to empower them by giving them that information and offering them support if they decide to take action. So it's not about not telling them, it's how you tell them. And also, and I think it'd be really interesting, Hazel, to do something on how you get those facts across, because I sometimes hear it's 25% more likely. That doesn't resonate with women. So maybe how we use language to enable those messages to be heard might be useful.
Let's come back to it for sure. There's loads of ideas for webinars in the chat, so Ash will be busy. I think this is not an unrelated point, and I again reflected in multiple of your presentations and in the chat. The kind of the role that women feel that smoking is playing in their lives that has value to them, this kind of particularly like linked to mental health. Sonya, I wonder if you could talk a bit more about that and the challenges that poses for the messages that we're giving women, that there is value that people are seeing in smoking and risk in quitting.
Yeah, so we know from just speaking to smokers generally, and it's the same for pregnant smokers, that they see smoking as a way of coping. It's a coping mechanism. It's very much linked to a stress diffuser, you know, a timeout. When things are getting too much for you, you can just take yourself outside and have a cigarette. It gives you time away from your toddlers, and I guess if you're pregnant and you've got toddlers around you as well, just to step out and have that time. So people very much see it as a tool for coping, and they also fear the difficulty of the quit. They know how hard that's going to be, and they know that that quit attempt will incur more stress because they'll be moody, they'll be, you know, suffering from the withdrawal from the nicotine, and so you're adding stress to me at the same time you're removing the thing that helps me deal with that stress. So it's like a double whammy. You know, we see with smokers just generally that anxiety, and well, it can the whole mental health thing, it can be sort of day-to-day stresses and dealing with a crappy job or dealing with the kids, through to people who suffer like severe mental health issues, that smoking is their way of coping, and that they fear things getting worse in that respect if they were to quit.
And we're now in a context where people's lives are going to be harder. You know, the cost of living crisis, you know, this is going to be a more stressful environment going forward, particularly for people on low incomes, which is often the population we're talking about here. And I know that for healthcare professionals, some of the midwives, some of the fear of kind of getting into these conversations is that trying to unpack all of that stuff about what smoking means to you and the fears that you have about quitting feels massive. I mean, how in that encounter where you're doing the carbon monoxide screening, you're identifying the smoking, you're trying to have the impactful conversation, how are we then building in an acknowledgement of what smoking means to people in a way that's not going to derail your whole booking conversation? Jane, I'll go to you and then Hilary. Sorry, I should.
Yeah, I think the issue is kind of for the midwife doing the basics, VBA and CO, is that making that referral is key, and then handing over to the experts, because what we don't want midwives to do is, you know I've handled conversations badly in the past by giving the wrong information with lack of training, and I think what we don't want to do is, like you say, collude with smoking or collude with the idea of cutting down being great, because I know I've said that, oh, cutting down's brilliant, but actually they'll smoke the 5 as hard as 20, you know. So I think it's making sure that you can just get across that the impetus around that referral and getting into the experts and letting the experts really begin to underpin that, which will then allow a really rich conversation, which might lead into more social prescribing and what really getting into the crux of why somebody's smoking. In a booking, you've not got that time. You're lucky if you've got 5 minutes. You know, you're kind of running at a race of knots to get so much in that hour that they've got. And I think rather than be detrimental to that future conversation, just get a referral and get them into the experts who are really going to be able to give that knowledge and sit down with the time to unravel all of that and see how they can support, as well as treatment and support.
And I guess you can acknowledge to people that they can if they're worried about this stuff, they can explore that with the specialist. They'll help them. That, you know, you don't have to get into it without, you know, saying that support is there. Hilary and then Sonya.
Yeah, I think that's really interesting, Jane. I think one of the things, the midwives haven't got that much time in those visits, so we have to use it really wisely, and you can pick up some of those what I count as heart sinks and use them to pass them on. So to say, do you know what, I've got a colleague who really knows about this stuff, would you have a conversation with them? So instead of being floored by or thinking, how can I spend half an hour doing this, I haven't got the time, turn it around and use it to promote having that conversation with that colleague who's going to really know that stuff. But just particularly at the moment, because of the financial stress, I think it's really important as well that I'm sure that's almost, people will be saying I'm smoking more when I really need to be smoking less as well. And I think where, Jane, during COVID, when we saw what women were using the vouchers for, they were saying they were using them for everyday spend, and we heard that far more during, over the last year or so than we've ever heard before. These families are often in financial, kind of dire straits. So I do think we have to maybe get back on that financial conversation a bit, and maybe think about CAB and, Hazel, social housing, financial discussions around it. Is help other colleagues come in on that?
Yeah, if we've got time, we'll come on to the wider professionals. Sonya.
So that's what I wanted to say follows on very nicely from what Hilary just said. I think we need to understand what's happening amongst the wider community of smokers with this cost of living crisis and what that's doing to their smoking. So a lot of moving to roll your own, and we know that rollies, it's more difficult, even if you're cutting down, it's more difficult to measure if you're cutting down. If you've got a packet of cigarettes, you can see that there's 2 gone. With rollies, you can't. And there's a significant move, I think, to illicit tobacco as well, and all of the harm that then throws up with it. So I think that those things, need to be on the radar as well. That smokers are going to, some of them are going to smoke whatever the crisis in cost is, and they're doing these things to help them cope.
And I think that's when we have a harm reduction conversation as well. I mean, there's lots and lots of conversation about e-cigarettes, the role of e-cigarettes in kind of facilitating some of these concerns that people have. But, the more that we can get people to move away from the most harmful consumption of nicotine, the better. Very quickly then, my final kind of couple of thoughts. I think there's been quite a bit of stuff being thrown. I thought that the point about the scans, getting more scans, being reassuring, and that message around smoking being harmful not being reinforced by the wider professions, because it's not necessarily the midwife undertaking that scan. Jane, is that something that you've tackled in GM?
Yeah, we've made it everybody's responsibility. So literally every person who works within our organisations gets the VBA training. So that could be our sonographers, that could be our maternity support workers, that's our doctors, because often we have doctor clinics now where women don't even see a midwife. So we really try and make sure that everybody's had a very brief advice conversation, and we're making it everybody's business, because it might be a 28-week appointment where you've got a bit of a growth issue, that sonographer might be that person that could have that conversation there in that moment to really engage women. So I think we're trying to take that whole system approach to everybody being able to have those conversations.
Brilliant. Okay, on that note, it's so rich. I think we're going to have a webinar in the future on e-cigarettes and pregnancy. We'll definitely come back to that. I think it would be very helpful for us to come back and do a session that talks about the harms from smoking, and then we'll also include how to talk to women about those harms, and fitting that within that VBA intervention in that sort of rapid conversation that we need to have to engage women into further support. And then there's lots and lots of chat in which we haven't even covered in the discussion around incentives and the role of incentives in the chat. We're hoping to update our briefing on that, so we'll kind of bring people back together to look at incentive schemes as well in the future. So thank you so much for all of the speakers and for the really, really useful content that you've shared. Thank you so much to all of the vibrant conversation in the chat. We'll kind of comb through it and see if there's anything else that we need to come back to people on, and look forward to continuing this conversation around the role of healthcare professionals, although with a greater focus on primary care, in our next session on the 18th of October. And if you want to get more stuck into the issues around cost of living crisis and disadvantaged smokers, then you could revisit the 2 webinars that we've already held, which were up online. Thanks for your time today, everybody, and we will leave it there. I seem to have somehow managed to wrap up 2 minutes early, which is very unlike me, but we will stop there. Thanks, everybody.
Thank you.
Thank you.
Thanks, Hazel.